नहीं तो इसमें पेन ड्राइव से ही मेरे इसमें लोड You want to start? Sure. Okay, we all welcome you to this session, which is in coordination and conducted by the Association of National Board of Accredited Institutions, ANBAI-ECHO. This is a web-based program, which I'm given to understand is done once in a month from different NB accredited institutions to facilitate the DNB training program for postgraduate students. So this time we are doing from the Gangaram Hospital, Sir Gangaram Hospital, New Delhi. And the topic is on primary immunodeficiency. Dr. Prakriti is Srivastava is our DNB trainee who will be presenting a brief case summary of the index case. And then possibly in next week, I think we will not be able to finish the whole case and the whole discussion in this session. And then subsequently, we'll be able to do it in subsequent sessions. So I welcome you all over here. I'm Dr. Kaul, a pediatric infectious disease consultant in this hospital. I have already introduced you about Dr. Prakriti Srivastava. My special thanks are to Mr. Satinder Negi and Miss Manisha Datta who have helped us to do a coordination, and IT give the IT expert coordination. Just a few reminders before we start the session. I would request you to keep your mobile phones in the silent mode. This session will be recorded for future purposes. We hope that we don't reveal any patient healthcare information or any patient identity. And we would request everyone to participate in this program actively, with obviously mutual respect. And you can open your chat box, and it's mandatory from the front video on. We repeat it every 15 minutes. You are also requested to write your names, the email IDs, the mobile numbers, and the name of the institute in the chat box every 15 minutes. So ask all your questions in the chat box. So we go ahead and start this session. Dr. Prakriti.
Good evening, everybody. My name is Dr. Prakriti, and I'm going to present the case. So, our case is the 9-month-old male infant resident of Gurgaon, Haryana, admitted with the chief complaints of loose stool for 2 weeks, vomiting which was intermittent for 2 weeks, lethargy and decreased activity for 2 to 3 days, and abdominal distension for 2 to 3 days. So, history of present illness: 9 months old male infant presented with a complaint of loose stool for 2 weeks, which were 3 to 4 times per day, watery, odorless, and not associated with blood or mucus. He also had non-bilious, non-projectile, intermittent vomiting for similar duration. For last 2 to 3 days, he had abdominal distension and was lethargic and had decreased activity. Coming to negative history, he had no history of fever, cough and cold, or traveling to outside, no history of weight loss, no swelling in cervical, axillary, and inguinal areas, no history of food allergy or recent drug intake, no complaint of irritability or any abnormal activity or seizure. Past history, baby had
I think you need to go a little slow. I think just because there are a lot of people. If they have, I think I can see a few people have joined us, but we need to go a little slow so that they can also have this is a sort of a two-way sort of an educational program for us. In fact, I'm doing this sort of exercise for the first time. I have done this thing long back with certain, we used to have a ISRO-based program doing a telemedicine for an outpatient people. Anyway, go ahead.
So past history, baby, our patient had been unwell for last 8 months. He developed loose stool at the 48 days of life, admitted in a nearby hospital and investigation. He was discharged with diagnosis of possible lactose intolerance and was given lactose-free milk formulation on discharge. He had also a history of infection at 8 months of age and had a history of axillary swelling and discharge from BCG site for 1 month. Coming to family and social history, father was an IT professional and mother was housewife. They had recently migrated to India from USA, so they had high socio-economic status, living in Gurgaon, and had monthly income of 3 to 4 lakhs rupees approximately. There was no history of tuberculosis or immunodeficiency disorder in any family members. Immunization history: the child has received BCG, OPV, DPT, and 3 doses of DPT, OPV, and HIP, and had not received measles vaccine. Developmental history was grossly normal, and had gross motor was that he was able to stand with support for a few minutes and can sit without support. Fine motor, the princess grasp was present, and he could waves bye-bye and language, and there was non-specific monosyllable sounds he could make. Nutritional history was that the child was well nourished for age. There was no evidence of protein allergy, malnutrition. He was on top weight mainly, and the weaning food was just started. Examination: anthropometry with the weight was 8.5, which was 50th centile on CDC chart. Height was 72 centimeter, which was between 25th to 50th centile. And head circumference was 44 centimeter, which was appropriate for the age. Coming to general physical examination, when the child was admitted, there were signs of dehydration were present. Pallor was present, whereas icterus, cyanosis, and clubbing was absent. Mild edema was present on bilateral feet. Lymph nodes were non-palpable, and temperature, the child was afebrile. Pulse was it was 110 per minute, and all peripheral pulses were palpable. The respiratory rate was 35 minutes, which was abdominothoracic. BP was 80 by 60 millimeter Hg in left arm. And since we have a GI complaints mainly, so we came to per abdominal examination. On inspection, there was mild distension. There was no swelling, no pulsation or venous prominence. No scar mark was seen. On palpation, the abdomen was soft, non-tender, with abdominal girth of 46 centimeter. Liver was enlarged 2 centimeter below right subcostal margin, and liver span was 12 centimeter, which was soft, non-tender, and smooth. Spleen was non-palpable, and no internal lymph nodes could be palpated. On percussion, there was no fluid thrill or shifting dullness. Auscultation, bowel sounds were exaggerated. Genitalia were normal, whereas other systems were normal. There was no abnormality could be seen. Respiratory system had bilateral air entry equal, no adventitious sounds were present. On cardiovascular system, both S1, S2 were audible, and there was no murmur. And CNS examination, sensorium was normal. The child was irritable, but he was GCS was 15 by 15. There was no cranial palsy. Motor and sensory examination system was normal. So our clinical differential diagnosis was that the child may have persistent diarrhea or secondary lactose intolerance. There was subacute intestinal obstruction, or there may be sepsis or immunodeficiency in view of recurrent history of recurrent infection.
So before you just go further, could you just summarize? Now you have this 9-month-old male child who had presented to you with primarily with a diarrhea, and he had been diagnosed as secondary lactose intolerance. So obviously there have to be the primary care physician at the initial when he was being taken care must have done the stool routine, the pH and the reducing substances, and he must have seen that there is evidence of a lactose intolerance. So looks like that since the baby did not have lactose intolerance right from the birth, and subsequently he developed it, and this is a secondary lactose intolerance. And that's why it's very difficult for us to just figure it out whether we have a primary or a secondary lactose intolerance. But since he had been put on lactose-free formulation, on a soy-based milk formulation, and he was doing okay. But you have other features that he had presented with something suggestive of an intestinal obstruction. Okay? And since he had recurrent infections, he had right from day 40th of life when he had presented for the first time with diarrhea, you see that he had been more or less having one or the other infection. So that's why immunodeficiency may be a possibility in this scenario. Okay, go ahead.
Sir, we should give history of last infection in details, but that much is sufficient.
Yes, it is very important for us to figure it out how many times he was. See, this is an 8-month-old child, and it looks like that he has had about 5 to 6 episodes of visit to the primary care pediatrician in last 9 months prior to he came to us. So this is in addition to the routine immunization, he had to get his routine immunization. So this sensitizes us that possibly you can't really put within 100% accuracy that no, this could still be an infection-related problem, but we have to keep an underlying immunodeficiency at the back of our mind. Go ahead, Said. So this is your investigation plan, what you did at the first admission. Okay. So can we have all the investigations?
So, if coming to course in hospital, on day 2 of admission, the child developed discrete lesion over trunk, abdomen, thighs, which was maculopapillar erythematous lesion, which was raised above the skin surface with violaceous hue. So, after skin, so, I'm sorry.
Okay, you're not. Can somebody help us? Satinder, can you help us with the?
नहीं वहाँ से चल रहा है कहाँ से ओपन किया नीचे बैक का
investigation.
So you need a list of investigations. Okay.
We had sent all the CBC videos. Routine investigations were sent, in which TLC counts were high, with differential having neutrophilic lymphocytic predominance. Peripheral smear was normal, and there were no atypical cells. ESR was also normal, with normal LFT and RFT. But the radiological examinations showed that in abdominal X-ray showed that multiple fluid level was seen, which was suggestive of subacute intestinal obstruction. So we went for CECT abdomen, which showed the evidence of ascites with thickened bowel loops, dilated small bowel, 2 small hypodense lesions seen in the spleen, which may be SOL, space occupying lesion. But since the child developed violaceous hue on the day 2 of admission, so skin biopsy was planned. So the child, the skin biopsy was done on day 5 of admission, and the report showed that acute on chronic inflammation with microabscesses formation in subcutaneous tissue, which was suggestive of paninculitis. The CCT abdomen showed the fluid collection on day 5 of admission. Ascitic tap was done, which was chylous in nature, showing 25 cells with lymphocytic predominance, and sugar was 82, proteins 1.5, albumin 0.7, with triglyceride of 300 and cholesterol 16. AFP TB culture was sent, which was negative. Gram stain showed no organism and culture was sterile. So since the child developed so rapid deterioration or rapid collection of the fluid, so we thought of immunodeficiency, and immunoglobulin profiles were sent, which was.
Okay, so before you shift, see, I have the possibly you can't open this slide in the window. This is the list of investigation. So the initial at the time of first admission, when the child came to us, his hemoglobin was 9.8, his TLC was 9,200, polys were 60%, neutrophils were 60%, lymphocytes were 25%, monos were 9, and eosinophils were 6. His blood culture was sterile. His CRP was elevated 96 milligrams per liter. So that means that he had either an inflammatory response or an infective response. This much is the information available. And then he had obviously, since he was a little dehydrated at the time of admission, he had a hyponatremic dehydration. His sodium was 121, potassium was 2.7. Okay. And he had proteins were a little low. That was 5 grams per deciliter, though the albumin was 3.5 grams. And since you subsequently, once he developed a prominent abdominal distension, the ultrasound confirmed that there was evidence of ascites, and the CT also confirmed that there was presence of ascites. So a consensus decision to do an ascitic tap was done to figure it out. What is the type of ascites? That normally everybody would like to see. You can do it either a bedside procedure, or it is better to do it in an ultrasound guided way, tapping the ascites. Here, to our surprise, we found out that this was a milky colored fluid. Okay, so this was a chylous ascites with very high triglyceride elevation. Okay, so this is a chylous ascites at this point of time.
Chat box है ना उसको भी open करके chat.
Sir, why bone marrow was done?
Okay, we'll go to the. This is a possibly she moved a little too fast. That why the bone marrow was done, because this child, this is in subsequently when we found out that this child had evidence of sepsis, he had evidence of, we were trying to do the bone marrow to send it for a TB culture so that we could grow organisms from, and you can get a lot of information from doing the bone marrow. So any child coming with hepatomegaly who has evidence of sepsis, whom you want to, and this is in fact an older case, way back, admitted in 2006. So at that time, we didn't have the expert facilities of doing the gene expert. So the technique of AFB culture from send it from either an ascites or for a bone marrow is acceptable thing. So that's why the bone marrow was done in this scenario. Can you go ahead? Next.
So bone marrow aspirations showed predominantly normoblastic erythroid cells, severe leukopenia with neutrophilic shift to left. Platelet decreased on smear, and treatment was, the child was kept NPO, IV fluids, IV antibiotics, and supportive care were given. And later on, the child was.
You're getting it. I'm sorry for the technical problems which are arising because she can't see her slides from the original screen. Why don't you open up your get your pen drive? I'll try to open up your presentation. Here's the presentation. You can open up your presentation from here.
Stop share.
अच्छा वो रिकॉर्डिंग चल रही है बंद नहीं आएगा थोड़ा हैंग हो रहा है
हाँ थोड़ा सा
मैसेज आया था ना वो मैसेज देख के मैसेज हट गया वो मैसेज के बाद ही हुआ सारा सर इस वाले में फिलहाल नहीं कर रही
techniques, the way you have a gene expert. This was something like a precursor to the gene expert. About few years back, we were doing a PCR-based test for detecting the TB organisms. So this is GeneProbe is the GeneProbe is the company which was making this commercial assay for TB. So this was used, and it is based on you are looking at the TB organisms based on your PCR assays. So I think it was from the ascitic tap, it was positive. So that means that there is evidence of tubercular ascites. So at this point, we know that this is tubercular. Okay, go ahead.
So from the previous skin biopsy, 6 weeks later, we again repeated the skin biopsy, and it revealed a AFP which was 4+ on ZN and DF staining. TB gene probe assay was again positive, and the AFP culture for Mycobacterium tuberculosis was positive after 15 days. Then again, antitubercular treatment was reinforced with parental nutrition. Child was also given antifungal septin prophylaxis for PCP.
See, now here comes the catch. You have now by this time you have a more or less little idea that we are dealing with a child with an immunodeficiency, and it looks like after seeing the immunoglobulin profile and after seeing the immunophenotyping profile that we are dealing with not hypogammaglobulinemia, not a neutrophilic defect, but this is a severe combined immunodeficiency. So both B cells as well as T cells are affected in this patient. So that's why we have to be a little more proactive in this, and such children can die with minor or major fungal infections. That's why it is very pertinent to start them on antifungal prophylaxis and Septron prophylaxis, because they can also get a PCP pneumonia. The way you start PCP in children with HIV infection, so if their CD4 counts are less than 15%, if they have severe immunosuppression in HIV infected children, they are started on PCP prophylaxis. So similarly, in this child also, in immunodeficient children, they can be started on PCP prophylaxis.
Child was again admitted at 12 months of age with complaint of decreased oral intake and loose stool for 2 days with cough and cold and respiratory distress. He also developed cutaneous skin lesions which are tuberculates and were in healing process, but no new lesions came. Again, he was managed with IV fluids, antibiotic, and he was already completed 2 months of antitubercular treatment. Again, at 2 months later, he was severely malnourished with lost 1.5 kilogram of weight, and was admitted with nearby hospital with a complaint of diarrhea for 2 days. He was brought to Ganga hospital in shock and respiratory distress. Was admitted in PICU, intubated, was hypothermic with respiratory metabolic acidosis, and died after 6 hours of admission with sepsis and shock.
So now you have this child. Can you summarize the case for us? Then we can have the sort of questions.
So, summary of the case is a 9-month-old male infant with history of recurrent past infection, diarrhea, ear infections, admitted with loose stools and vomiting and abdominal distension. He was evaluated and diagnosed as persistent diarrhea with sepsis with subacute intestinal obstruction and intestinal lymphangiectasia. On subsequent admission, he was after 1 week, he had a progressive abdominal distension with subcutaneous abdominal nodules which grew AFB. Bone marrow culture sensitivity also revealed evidence of AFB on DF stain and subsequent TB culture. In view of persistent BCG lymphadenitis and chylous ascites, child was evaluated for underlying immunodeficiency. Immunoglobulin assays and phenotyping revealed evidence of severe combined immunodeficiency with disseminated mycobacterial TB infection, possibly due to BCG-induced scar, disseminated TB. He was started on antitubercular treatment in second admission along with antibiotics and supportive received periodic IVIG infusions to sustain immunoglobulin G level above 500 milligram per day. Parents were counseled for bone marrow transplant in view of subacute combined immunodeficiency, but no identifiable HLA match was found. Child had deteriorated in subsequent months and was admitted with septic shock in PICU in last admission. However, he succumbed to his illness within 6 hours of admission. Subsequently, parents were advised for genetic counseling for the next pregnancy. So our final diagnosis was severe combined immunodeficiency with disseminated BCG tuberculosis with intestinal lymphangiectasia with refractive shock, possible due to interferon gamma receptor or interleukin 12 receptor defect.
So now she has summarized some of the details of this case, but the learning exercise in this case is that we have been able to get to the possible etiological diagnosis only after second or third admission. At the first admission, we were not able to make an etiological diagnosis because the AFB was negative, the culture did not reveal anything. But this is the natural course of the illness. Subsequently, after a week or 2 weeks, he had become much sicker. He had a second prolonged course of hospitalization, and in that he developed a violaceous rash over the trunk and abdomen, and he had a persistent BCG lymphadenitis where there was a draining sinus. So a lot of sites, the bone marrow, the BCG lymphadenitis site, the blood cultures, all grew Mycobacterium tuberculosis, and all of them were Mycobacterium tuberculosis bovis, because these mycobacterial isolates were subsequently analyzed in a different lab with different tests, because you can differentiate between Mycobacterium tuberculosis bovis and Mycobacterial tuberculosis hominis on certain tests. So a good microbiology lab will do certain biochemical tests, and at the same time, if you find out these organisms are resistant to pyrazinamide and possibly this is Mycobacterium tuberculosis bovis, because this child had received a BCG vaccine and subsequently had developed a BCG lymphadenitis. So if you see a lot of children who receive BCG developed axillary lymphadenitis, but their immune system is able to contain the BCG lymphadenitis, and they don't develop disseminated BCG infection. But in children who have severe combined immunodeficiency, so it could be either a B cell deficiency or a T cell deficiency or a NK cell deficiency, depending upon the type of deficiency they have, which we'll discuss in later. So they can have very fulminant BCG infection, and they can develop BCG, disseminated BCG tuberculosis. That's what we see in this case. Now, the thing is that why did he develop chylus and ascites? So as a part of his illness only, he had a lot of possibly this could be a second etiology. Did he have there's an entity called congenital intestinal lymphangiectasia. These children are born without adequate lymphatic system, and they have called a congenital intestinal lymphangiectasia. So they will present early in the first year of life, but here he had two conditions going together possibly. And then obviously, as one would expect, that they don't have a very good immune system, and because of that, he developed a refractory shock and he died. Okay, we don't have so the story doesn't end here for these children. Very sophisticated labs can find out the genetic defect in such children. In fact, we should be analyzing what is the molecular defect. So keeping the history, the physical findings, the immunohematological profile, we think that possibly there is an interferon gamma receptor defect or an interleukin 12 receptor defect. Because if you have this entity, such children are very vulnerable to disseminated BCG infection, or they can get repeated typhoid infections. They can get repeated TB infections. Okay, so this is the learning exercise from this exercise, that one, how BCG can be fatal. But here I don't want to give you the impression that we stop giving BCG to all newborns. This is a very rare occurrence. About 1 in 1 million children will get this sort of a problem. Or they can develop sometimes a multifocal BCG-induced osteomyelitis. So there have been case reports where they have found out multifocal osteomyelitis. So she has here one more slide to see how we differentiate the mycobacterial tuberculosis identification. We can go ahead with this. So go ahead with this slide. The previous slide. Yeah. So,
Organisms, Mycobacterium tuberculosis complex was identified. So there were two strains, Mycobacterium tuberculosis bovis or Mycobacterium tuberculosis hominis. So bovis are their nitrate and niacin negative, pyrazinamide resistant, and have disobonic growth in comparison to Mycobacterium tuberculosis hominis.
So this is what I was talking. This is what your very good microbial lab, a microbiologist will help you out to differentiate whether this is Mycobacterial tuberculosis and Mycobacterial hominis. But here, since there is possibility a relationship with the BCG lymphadenitis, so possibly it looks like that this is a BCG tuberculosis bovis. Okay, then we are talking about one more condition called, go ahead with this slide, next slide. Can we get the next slide? Okay, so this is a condition called Mendelian susceptibility to mycobacterial infections. This is a new thing which we have learned in last say 5 years or so, that such children can get, we have in our clinics also children coming with repeated episodes of TB. Their TB doesn't become okay. You put them on ATT, the moment you put them in the continuation phase, they get a recurrence of a cervical lymphadenopathy or a node somewhere here or elsewhere. So they have a particular genetic defect, which we call is a Mendelian susceptibility to mycobacterial tubercular infections. There are a lot of genetic defects in these situations. Okay, so we don't have a complete understanding of this phenomena till now, but people are trying to work. People think that it could be either a single gene polymorphism, okay, which has been seen in a single nucleotide polymorphism. Polymorphism is basically a different from a mutation. Mutation more or less always gives a phenotypic expression, but polymorphism is a deviation from a normal nucleotide sequence where it may or it may not give a phenotypic expression. Okay, so this is called a SNP. So these children who have this SNP are susceptible to repeated TB infections. Then there are reports that children or adults who have defects in the toll-like receptor 2 and toll-like receptor 10, they are susceptible to these infections. And this we have already talked about. If there is an interferon gamma receptor defect, or if there is an interleukin 12 receptor defect, because they are very important in immune regulation pathways for the microbes. And if you have a defect in any of these genetic defects in these, it will lead to a phenotypic expression in the absence of these receptors, or you may have a STAT1 mutation So such children are more vulnerable to TB infections. Okay. Maybe in next session we can have an sort of an approach where we give an algorithmic approach to immunodeficiency, because immunodeficiency is a very wide sort of spectrum of illnesses, and you may be seeing these conditions in your day-to-day practice in your clinics. So she will try to give an algorithmic approach. How will you really look for such children with immunodeficiency in the clinics? So they can present with repeated infections, they can present with autoimmune problems, children who are having SLE, who are having juvenile arthritis, or who are having multifocal osteomyelitis can have an underlying immunodeficiency. Or we can have certain very subtle defects like neutrophilic defects, like CGD or leukocyte adhesion defects, where the defect is in the neutrophils. So that's what we'll be dealing with in the next session. Thank you. That's all. Satinder, done? Sure. Right. So you can give your feedback and share in the chat mail in case you want a second sessions, and then we can continue it with in the next maybe next Saturday.